Så varmt välkomna till AFA Försäkrings frukostseminarium om en ny färsk kunskapsöversikt om Tumbasartros. AFA Försäkring, vi ägs ju av arbetsmarknadens parter, Svenskt Näringsliv, LO och PTK. Och våra största uppdragsgivare är ju kommuner och landsting. Och vi hanterar de kollektivavtalade försäkringarna. Men vi gör också väldigt mycket förebyggande arbete för att förebygga ohälsa och arbetsskador. Och en del i det arbetet är att vi finansierar kunskapsöversikter. Bland annat för att se de försäkringsmedicinska sambandsbedömningar, kunskap för arbetsmiljöarbete och underlag för prioritering av forskning. Och det här arbetet det samordnas av Arbets- och Miljømedicinsk vid Göteborgs universitet och publiceras då i Arbete och hälsa i den tidskriften. Och idag har vi då två forskare, Christina Bach Lund och Jane Frölund Thomsen vid Arbets- och Miljømedicinska avdelningen i Bispebjerg sjukhus vid Köpenhamn som ska få presentera den här helt nya och färska rapporten. Så varsågod.
Can you hear me? Yeah. Thank you so much for having me. Thank you for the invitation. My name is Christina Bach Lund, and I'm a medical doctor and currently a PhD student at the Department of Occupational and Environmental Medicine at Bispebjerg Hospital in Copenhagen. And I'm here to tell you about this review with the title Work-Related Risk Factors in Thumb Carbometatarsal Arthrosis. I did it together with Sigurd Mikkelsen and Jane Frølund Thomsen, who's also here today. And I'm here to tell you about the results. So first of all, let me lead you through the process of this review. We were invited to do it in March 2017. We were invited by Arbejds og hälsa. And the literature search started off in July and went through August. And from September and until February 2018, we did all the study assessment and all the writing. From February until April 2018, the paper was reviewed by Michael Forsman and Martin Englund. And when we got their comments back, we made the final corrections and delivered the final paper in June 2018. And now I'm here presenting this work, and I'm happy to do that. The project is funded by Arbejds og hälsa, and I can understand also AFA Forsikring. So tak for det. Yeah, but let me start off by saying that a little bit about thumb carbometatarsal arthrosis. From this slide on, I will refer to it as CMC1 arthrosis. So here is a healthy joint, and here is a joint with osteoarthritis. CMC1 arthrosis is down here in the joint between the trapezium, the carpal called trapezium, and the first metacarpal. It's characterized by a joint space narrowing. You can see that the space, healthy space, is gone, and there are some extra bone material collected here, and that's what we call osteophytes. And sometimes you can even see cysts in the joint near bone. So what do the patients come to us about as medical doctors? Well, they come and tell us that they feel pain in their joint, and they feel a decreased strength when using the thumb and the hand, and they feel a decreased range of motion when using the hand. When we investigate that, we find swelling of the joint, and we find stiffness in the movements, and of course we find tenderness when we palpate it. Often the patients tell us that they have trouble pinching. Using the pinch grip is when you collect coins from a table, for instance, or write with a pencil. And they have trouble gripping like a handle or opening a jar. And of course, this can limit their work if their work are dominated by manual handling. When we look at the symptoms and the radiological findings, we find that they overlap, but not totally. That means that we can have patients who have clear symptoms of arthrosis, but when we take a radiograph, we can't find the typical findings. But it also means that, on the other hand, we can have a radiograph with typical findings, and when we ask the patients if they have symptoms, they haven't got any. And that's quite important when we when we look at the prevalences. In the first study here, in the first table, the diagnosis is based on a doctor diagnosis. I mean, both with symptoms and radiographs, and we find that the prevalence in the age group 20 to 25, for men, we find the prevalence to be 0.6%, and for women, 2.2%. In the age group 80 to 85, for men, it's 1.9%, and for women, it's 4.0%. In the lower table, where diagnosis is based only on radiographs, we see that men have and women have a much higher risk of disease, above 30%. So there's a big difference in how we define the diagnosis. So what can we do with the patients that has CMC1 arthrosis? Well, the conservative way of treating them is by the use of splints that immobilizes the joint and gives some rest and relieve the pain. If that's not enough, they can be referred to operation in the severe cases. Yeah, so what do we know about individual risk factors? Well, we know that age is a risk factor, and we also think we know that sex is a risk factor, but we don't really know any other risk factors for sure. So, when looking through literature, we find that experimental studies has shown an association between biomechanical stress and changes in bone and cartilage. We also find that epidemiological studies have shown an association between hand-arm vibrations and arthrosis of the hand, but not specifically for CMC1 arthrosis. It's more general arthrosis of the hand. So that leads to the hypothesis of several work-related, that there are potentially these work-related risk factors: repetition, precision, force, and force can be divided, as I said before, into pinch grip and hand grip. And then, of course, hand-arm vibrations. Yeah. So what has the literature up until now shown us? Well, in 2014, a meta-analysis by Hammer et al. Found an increased risk for pinch grip above 2. But in the final conclusion, they stated that limited support to the hypothesis that work activities requiring repeated and or sustained pinch grip contribute to the occurrence of finger or wrist osteoarthrosis. And regarding the association of occupational exposure to force grip and hand-arm vibration with finger or wrist osteoarthritis, the current evidence is insufficient. And they based that on the fact that there were major limitations of the included studies. Yeah. So that leads us to the next question, the research question: what do we know about work-related risk factors in CMC1 arthrosis specifically? And what do we know about other risk factors? Yeah. So what we did was that, I'll just go back. The first question up here was answered by the systematic review, whereas the last question here was answered by going through the recent 2 reviews we found. Yeah. But the systematic review, what we did was that we searched PubMed and Embase, and we used these keywords. And then we did a search in the Cochrane Library, a search for randomized controlled trials. And in the end, we compared what we found with previous reviews and their reference lists. We defined some inclusion criteria. CMC1 arthrosis had to be diagnosed by either clinical examination and or radiographs, and exposure had to be based on job title or information on specific exposures. Inclusion of a control group with little or no exposure. There had to be included a control group with little or no exposure, and there had to be a risk estimate, either already calculated or data for us to calculate it. And all methods of exposure assessment were included. We excluded case studies and experimental studies. So here are the results of the search. We identified more than 3,000 studies in PubMed. After a screening by title and abstract, we excluded almost 3,000 studies. We went through 25 full-text assessments, and after that we excluded 18 studies. 4 of them had different case definitions. 1 had a different exposure than we thought, and 1 had no exposure. 1 had no control group, and 1 turned out to be a correspondence. After that, we added a single study based on the reading of the reviews and the reference list. So we ended up with 8 studies included. As I said before, we also searched Embase, and we found almost 1,800 studies there. But after screening by title, abstract, and the full-text assessments, it couldn't supply us with further studies. And the same was true for the search in Cochrane Library. Yeah. Okay, so let me walk you through the studies that we included. The first one is by Kellgren from 1958. It's a cross-sectional study, and it included 271 cotton workers and mine workers. The exposure was based on job title, and the diagnosis was based on radiographs. The results showed an increased risk for cotton workers in total, both men and women. And here I don't know how familiar you are with odds ratios, but if it's above 1, it's an increased risk, and below 1, it's a decreased risk. And here are the confidence intervals. So cotton workers in total showed an increased risk, and the male cotton workers also showed an increased risk. The female cotton workers, the results of the female cotton workers didn't show an increased risk, neither did the mine workers. Yeah, so this study has some strengths and weaknesses. For instance, there was a lower age in the control group compared with the exposed group. No, sorry, that's the other way around. There was a lower age in the exposed group than in the control group. They didn't adjust for it in the analysis, which means that the association could be even stronger. There were no blinding when diagnosing CMC1, and there were no clinical parameters used when diagnosing CMC1. Yeah. Moving on to the study by Lawrence et al. From 1961, which was also a cross-sectional study. It included 340 cotton workers, and they also had exposure based on self-reported job title. The diagnosis was again determined by radiographs. The results from this study showed that cotton workers in general, both men and women, had an increased risk of getting CMC1 arthrosis. And the same was true for men, but not women. So similar results as the study by Kellgren. This study also had strengths and weaknesses. The control group were matched by age and sex, which is a strength. It's also a strength that they used blinding when diagnosing CMC1. On the other hand, there were no clinical parameters used when diagnosing CMC1 arthrosis. Yeah, so when we look at the two studies together, Kellgren and Lawrence study, we find that the study populations are partly overlapping and that the control groups are the same in both studies, which means that we cannot interpret them as two completely different studies and neither their results. On top of that, there was a non-consistency in the terminology regarding CMC1 in the studies when we read them. Yeah. The next study is by Kessler et al. From 2003. It's also a cross-sectional study. It included 639 patients that were already admitted to the hospital to have a knee or hip replacement. They had self-reported heavy physical exertion as exposure, and the diagnosis was based on radiographs as well. The results showed no positive association between heavy physical load when compared to moderate, light, or no physical activity. Yeah. This study also had strengths and limitations. For instance, there were no detailed information on exposure, especially there were no detailed information on hand exposure. The control group might be exposed as it included moderate physical activity. And that could mean that it's difficult to find an association if there was one. It's a strength that they were blinded with regards to name, sex, and age, but we actually don't know if they were blinded with regards to exposure, and that's a weakness. The analysis were adjusted for age, sex, hip and knee arthrosis, BMI, hypertension, and diabetes. The next study is by Marshall et al. From 2013. It's also a cross-sectional study. It included 1,076 persons. They all had an age of 50 or above, and they all had symptoms of the hands in terms of pain and stiffness. Exposure was based on self-reported excessive use of hands in employment or pastimes. The diagnosis was based on both symptoms and radiographs this time. Results showed an excessive use of hands, in employment or pastimes had no positive association to CMC1 arthrosis. The RRR is interpreted in the same way as odds ratios. Yeah, so this study, in this study, exposure included both work-related and private risk factors, which is a clear limitation when interpreting the results. And there were no information on blinding. On the other hand, the analyses were adjusted for age and sex, and they had assessed the intra and inter-rater reliability and found it excellent and moderate. Yeah. The study by Hara et al. From 2004 was also a cross-sectional study. It included 3,597 persons at the age of 30 or above. They included self-reported work-related risk factors as exposures, and they asked them about these exposures: lifting, carrying, awkward postures, full body vibrations, work with vibrating tools, repetitive work, and work with machines. And then they gave them a score of 0 or 1 and put it all together. Diagnosis was based on symptoms and radiographs. And they put them into these exposure groups depending on how many points they got. And of course, those with 0 points were the reference group. And as you can see, there were no positive association found. no matter how high a group they were in. Yeah. In this study, there was an uncertain size of control group, which limits it a bit. Exposure was not specific for the hands. However, diagnosis was blinded to exposure status, and the analysis were adjusted for age, sex, BMI, smoking, and educational level. A study by Caspi et al. From 2001 was also a cross-sectional study. It included 553 geriatric patients, and the exposure were based on a combination of self-reported exposures and expert-rated degree of lifelong hand strain and hand requirements. So they combined the two things. Diagnosis was based on radiographs. They found no significant association, but they didn't show data in the article, so we can't show them here. It was a strength that they were blinded when doing the diagnosing, but there were no information on adjustment for potential confounders. And confounders, I don't know if you're familiar with that expression. You are? Yeah. Okay. Jones et al. From 2002 made a cross-sectional study with 522 persons with at least one living relative with arthrosis of the hand. They combined again a self-reported and expert-rated degree of work with mechanical stress to the hand. Diagnosis was based on radiographs, and the analysis they did showed no positive association between high degree of mechanical stress and the development of CMC1. This study had a very selected population that could have different risks, as they were included as part of a another genetic study. So that's a limitation of the study. On the other hand, they adjusted for age, sex, and interaction between age and sex, BMI and family status. And again, they did an intra-observer variation assessment and found it good. The last study is by Fontana et al. From 2007. It's the only case reference study of this review, and it included 61 women admitted to surgery because of CMC1 arthrosis. They were matched by age and of course also sex to 120 controls. And exposure were based on expert-rated either manual jobs or jobs with an increased, with CMC1 risk factors. And above that, they also had a self-rated exposure to specific risk factors. The results of that study showed that jobs with higher risk of CMC1, defined by the authors, primarily secretaries, tailors, hat makers, sewing machinists, broiders, and similar jobs, and then cleaning assistants, showed a positive association with CMC1 arthrosis, with a risk estimate of 3.78 and a confidence interval above 1. It also showed a positive association between repetitive work with the thumb and the development of CMC1 arthrosis, with a quite high risk estimate, but also a quite wide confidence interval. And finally, it showed an association, positive association between jobs where the patients thought they had too few breaks and the development of CMC1 arthrosis. Again, a quite high risk estimate, but also a wide confidence interval. Yeah. So this study was limited, had a strength in the adjustment for age and smoking, obesity, familiar disposition, hysterectomy, parity, and temporary jobs. Okay, so I made this overview. And yeah, I listed the studies out here. And in the first column, we have study design. And as you can see, it's almost all cross-sectional. we have the only case reference study down here at Fontana. Cross-sectional studies are limited in the way that they cannot say so much about causality, because you measure in cross-sectional studies, you measure exposure and outcome at the same time, so you don't know whichever came first. So that's a general limitation in this review. When we look at the population, as I said before, the two first studies by Kilgren and Lawrence had overlapping study populations and the same control group, which means that they cannot be interpreted as two different studies. In the Kessler study, the control group might be exposed as it included moderate exposed people. And down here in the studies by Jones and Fontana, we had a quite selected group of people. In the Jones study, it was people with relatives having arthrosis, and down here it was patients admitted to hospital for surgery, CMC1 arthrosis surgery. And of course, they can have a different exposure in general, as people with a high exposure tend to go to surgery faster than others. In this column, we focus on how specific the exposure definition was. In order to assess causality, it's very important to have specific exposure measures, also in terms of prevention later on. We found that most of the studies didn't have a specific exposure definition, which again is a limitation. In reporting of exposure, we found that most of the study had self-reported exposure reporting, which we know can bias the results, as you tend to report a higher exposure if you have pain. And the other way around, if you feel fine, you tend to report lesser exposure. So again, these are limitations. Over here we have a list of blinding. It's very important when you diagnose CMC1 arthrosis that you are blinded to exposure, because we know if you know how the exposure has been, and if you know that the exposure has been high, you tend to you tend to see cases. And the other way around, if you know that the patient or the person hasn't been exposed, then you tend not to see cases. So it's very important that you have a blinded setup in order to avoid classification bias. Looking at the outcome definition, we prefer a combination of symptoms and radiographs or doctor-diagnosed outcome. Most of these were based solely on radiographs, except from these and the last one from Fontana. And finally, when doing these studies, it's very important that you have confounder control. That means that you adjust for for other risk factors that could affect the results of the association. And at this point, they were quite good. Most of them had confounder control, and the most important confounder control we find to be age and sex, as we know that they are potential risk factors. Some of the studies we were unsure if they had confounder control because they didn't write anything about it in the paper. Yeah, so what do we know about the other individual risk factors, the second part of the question? Well, we went through two recent reviews by Kalikman et al. From 2010 and a meta-analysis of Hammer et al. From 2014. They confirmed that age and sex were risk factors. It looks as if the risk increases from the age of 45, and that women have a higher risk of CMC1 arthrosis than men. The higher risk for women has led to the hypothesis that it could be a hormonal reason for the higher risk, which is why studies have investigated hysterectomized women. However, the results of those studies have been contradictory. Fracture has been associated to it, but not shown as finally to be a risk factor. The same goes for hypermobility and individual grip force. Obesity has been linked to hand arthrosis, but not CMC1 arthrosis particular. Yeah, so that's what we know about that. So, the conclusion. Few studies, only 3, and if we put the Kellgren and Lawrence study together, only 2 studies found a positive association between repetitive work of the thumb or jobs characterized by repetitive work tasks for the hands and CMC1 arthrosis. More studies found no association, and all studies had limitations. So, the evidence is assessed as insufficient to establish an association between work-related risk factors of the thumb and the development of CMC1 arthrosis. Our emphasis is put on that in reality only 2 studies, there were only 2 studies with a positive association, and that both studies that showed a positive association were limited by reporting bias, blinding, confounder control, and poorly defined exposure. Yeah, so what are the perspectives? We need further studies, but we need further studies that focuses on a precise exposure definition. Preferably, it would be nice to have studies with electronic measurements done, but we don't know of any techniques to do that. And of course, it can be very expensive to do those kind of studies. You could also do an expert-based job exposure matrix where you have experts assess people's exposure. However, it can be very difficult to assess to what degree a thumb is exposed to biomechanical stress in a job. So it's not as simple as we could hope. On top of that, we need some prospective design studies in order to assess the causality between work-related risk factors and the development of CMC1 arthrosis. Yeah, and finally I would like to say thank you to Professor Kjell Thorén from Arbejds and the reviewers Mikael Forsman and Martin Englund, and of course also AFA for having us and for funding us through Arbejds. Yeah, thank you.